What difficulties we might face during nailing, mostly the tens which we use in pediatric patients. So this is a 10-year boy. So option of treatment in transverse midshaft fracture is obviously going to be tens. It has worked well in this patient, but sometimes it doesn't work, or there are some problems even after nailing. So what they can be? It can be skin irritation, it can be bursitis, it can be knee stiffness, it can be effusion, or sometimes you may land up in loss of reduction or angulation. So why this problem occurs in tens? So the main cause of this irritation or synovial thickening of the bursa is the prominent ends or the curved ends. So can we prevent this? What are the tips to make it simple, to make it uncomplicated? So the tip of the end, this distal end, should be opposed to the metaphyseal flare of the femur. The nail end should lie at the level of the physis. And while impacting the nail, this is the impactor you can use, or this is the punch you can use, which has a stopper and a hollow end. So it will not cause the damage to the bone, and it will leave some tip of the nail behind or out of the bone, so it is easy to withdraw. Also we can use the cutter. This is a regular cutter you use. This is a jumbo cutter, but obviously this has high chances of causing irritation or the injury to the skin at the insertion site. So better use a more sophisticated cutters for cutting the nail in one go and clearly. Now what about the entry point, the portal of entry? There are chances that it can cause injury. And what is an ideal entry point? It is almost around 2.5 centimeter to 1 inch above the physeal line, or you can just take a flare where the metaphyseal flare starts getting widening up. You can take that point as an entry point. Use a straight awl initially, and then you can use a curved awl for better entry of the nail. You can also use this kind of an artery which has a blunt tip to enter, and you can make an oblique entry. Obviously the nail tip is very important, because the above slide is an ideal important nails, tens nails, and the below slide is what the Indian tens nails tip is. So you can see how the Indian nails are a bit straight, they are sharp, and they are long. So there are chances that they can get stuck into the opposite cortex very easily. So which implant we use, that also matters, or else we have to bend the tip also little bit to get a proper and comfortable entry point. And then why this loss of reduction or angulation can occur even after doing nailing tens? So it is because of a nail mismatch, one thick nail, one small nail. The thicker nail will have convexity. Sometimes the diameter of the nail is not proper. It might be thicker nails both sides, or it can be an inadequate fixation. As this case, there is only a single nail has been passed. So the other factors which can be considered is the age of the patient. Above 11 years, routinely the tens should not be used. And obviously the weight of the patient is also one of the cause. If above 50 kg weight, you try to avoid tens. And then other guidelines are the size of the nail has to be at least 40% of the diameter of the internal canal of the femur at isthmus level. The bending has to be curved and smooth. It should not be an acute bend when you are inserting the nail. So if you cross the nail many a times, or it is an S curve, or you try to rotate the nail, then obviously later on there are the chances that it may land up in a failure of the construct, or there is an angulation, or there can be a malunion. So also one factor we should consider is the geometry of the fracture and the location. So more distal fractures, or towards the end of the long bone of the femur, like it can be, if it is more towards the trochanteric area, you should be very wise to you decide which nail or which implant to use for fixation. In this case wise, you may not be always lucky as this case. Again, one more point is the quality of implant, which I had told you just now. The Indian implant, you can see there is, while inserting or while holding it with the T handle and trying to push it, they can get bend, acute bends, or you may find that they are losing the color code. The quality has to be very good if you are using tens implants. And then this is another a case of a girl of 6-year-old with a long oblique fracture. In this case, we have used tens with X-fix to prevent the collapse. Okay, and this is the X-ray after 1 month after the removal of the X-fix or the JES. And these are the results after 6 months. So many a times you may have to use assistance of some other system, or sometimes in some patients spica can also be used. And last is the removal of the nail. It's better to use the very good nozzle implant to hold the nail tightly and take it out easily to avoid the damage to the physis, which is very nearby to the tip of the nail. Sometimes we have to go for rigid intramedullary nails. Obviously, the more elder patients, but beware of the entry. It has to be more lateral towards the GT to prevent the damage to the lateral ascending circumflex branch of the medial femoral artery. Then the tips, you should have proper patient selection, nail selection, size selection. Entry point has to be good. The tip, the distal tip should be cut well at the proper level. You should keep away from the longer fractures, lateral entry for the rigid nails, and if required, you can use an assistance of other systems. Thank you.